So, dear colleagues, we here. I would like to say hello from Zagreb, from Croatia. I'm very excited for this experience because this is my first time for speaking without the audience. I'm the one who would like to have always the touch with the audience, and at that time you see how interesting you are or how boring you are. But this is the situation which we are all now in the same situation, for staying at home and using this opportunity without practicing dentistry to listen to webinars and to get some education online. And that's, I hope you will enjoy also this webinar today. I will speak about some let's say modern approach to a dentistry which implementing digital tools, and we will pass some with one nice case which is done on combination of digital and analog way. I hope all of you will enjoy the next hour, and I hope you are all staying safe in your home, and I'm pretty sure that all of you are missing dentistry as I'm missing. So I hope we'll also that we will very soon in every country in Europe start to practicing dentistry. So I will open my presentation and we will start. So as you see on the title, we will speak about full mouth reconstruction. So as I mentioned before, I don't know who is now sitting in front of the screen in the audience. It's it's very nice to introduce yourself when you're starting. So there is a one short video of my clinic, of my people. We are situated in Zagreb, in capital of Croatia. We are working in one small clinic. This is my clinic. We are practicing general dentistry, and we are specialized clinic for pediatric dentistry and prosthodontics. So most of my You see me?
You can
So
restart the session.
I can start the session, okay?
Yeah.
Will I start from the beginning?
No. Just continue.
Yeah. Okay.
At the moment you stopped.
Okay. So we had some technical problems as you saw. So I don't know where I stopped. So I will speak about. I start with this slide for maybe I'll repeat some things. Just to share the screen. So when you speak about modern dentistry, as I said before, this means like contemporary dentistry. This is not like you want to be modern to have nice suit when you're working, but to be modern, to be contemporary, it's very important you have to stick with all this which is said on the screen. It was easier I think 20, 30 years ago, it was easier to be a dentist because there was no so many material, there was no so technologies, there was no so many preparations technique, and you have only to answer on the patient's demand, on their request, to increase their look, to make their smile, reestablish their smile harmony, to make them new healthy smile, and the patient demands didn't change. They still want to look nice. They want to they want to jaw properly, to have a proper pronunciation, and nowadays to be a modern dentist, you have to be minimal invasive, you have to be digital, you have to be scientifically based, everything you work, because technology is taking you further, pushing you further, and there is no today, to be honest, you can be a modern practitioner if you prepare much at the time and you have new ceramics, new adhesion methods, good cements, and this is what I mean by modern dentistry. When patient come to your office, when patient come in my office, there is one aesthetic, I would say, individual aesthetic treatment plan, because we are dealing with we are speaking about cosmetic and aesthetic dentistry. There is always same procedure for approach to the patient, approach to the new case. First of all, we need to have X-ray, we need to do good photos, and we need to do impressions for the stone models. In the modern time, in the recent time, as we scan every patient. This is the generally procedure for the first appearance patients in our office. It's very important by the visiting patient first time. It's very important to listen for him, why he came to us, what he wants from us, to get clear with his demands. I do it in that way. When I'm doing the first checkup, I'm try to have one of my colleagues from my team to be with me, and they are writing or typing all impressions regarding speech between me and the patient. So it's easier for us, after analyzing the photos, after analyzing the scan and stone models, to have a good treatment, to make a proper treatment plan for this patient. According to this, when I make a plan, I very precisely define how will I approach to the case? What are my treatment goals? Is it male or female? What shape of tooth will I choose? What color of is the best for these patients? I would like to do a good selection between all ceramic materials which I can use. Of course, which ceramic material I will use, that will define my preparation design, and it will be in the future choose how I cemented this to the tooth. This case which you will see today, this is the combination of digital and analog way. I was in very short steps. I will explain you how is the procedure when I'm doing analog and what's the procedure when I'm doing digital. When we have an analog approach, which still most of I believe most of this audience are doing, there is always the same procedure of photography. We need a good dental photography for our documentation and for the comparison with the before and after with the patient. After that, we use impressions for the WhatsApp and the Facebook registration and sending all this to our dental lab. After that, our technician will do the pre-op models. He will get the stone models. He will put it in the articulator, and he will start to doing WhatsApp. And some of my technicians are giving me immediately silicone key after the WhatsApp, or some of them are just send me WhatsApp, and we will do in our practice the silicone key. In the third step, this is the most important step for I think for the patient, most of the time, and for us, we will do mock-up, and it's very emotional and very important phase if you want to show the patient the new shape and the new outcome of his smile and of his look. And let's say that patient is approved, he liked it, and we start to do OI preparation and final impression. After we are sending our impression to the dental lab, the dental technician will do units which we ask him to do, or that it could be crowns, veneers, depends on the case to case. And then the step 5, we will do this is for me the hardest part, because the bonding is something which takes a lot of time, as we will see furthermore in the case. And we do occlusion check and final photo. I do it immediately because sometimes people are not so, their obligation is to come after 2 weeks in our practice, but they come, sometimes they forget because they feel comfortable and everything is okay, so they come later on. Digital approach a little bit different. This also had 5 steps, but there is all these steps are much quicker because of the possibilities which digital dentistry are giving to us. The first step is almost the same. Always we do the photographies, always do the intraoral and extraoral photographies, and we don't take impression here. We do a digital impression. It means we scan both jaws, and we are doing the this scan we are sending to our dental lab, and after that, our dental technician will design in digital way WhatsApp, and he will print it model, and he will put plastic foil on it, which will be used to transfer the mock-up in the patient mouth. So the third step by the mock-up is almost the same. We will when we see that we are satisfied with the form, and the patient is very improved, is also satisfied with how he is looking, we start to do the preparation, and we will now do the final scan for the and sending to the dental technician. after that, veneering crowns will be manufacturing, and step 5 will be the same as the analog way. The difference is we don't have to send delivery to our dental labs. We are much quicker when we are sent on the like STL file or to our dental lab, and that, we can say that the most important way for me why I am digital, because I save my time. No one of us will count when we on our price list how much cost our time, and we have to think about it very much. This is the case which I'll show you today. It will be some combination between these two steps. Why I say combination? This is all you will see done digitally. But for example, we done wax up on analog way. This is how we mostly do now. We produce some good cases in totally digital form, where there was no tray or anything else in the patient's mouth instead of the scanner. But mostly now we are doing on this way. This is the very young patient. He is 28 years old, and he appeared in our office for very clearly with very clear demands. He were visiting dental offices, as he said, very often, but for some of feeling fell down or calculus removing, and he now wanted for the long-term period to increase his smile, and it was no problem in the first checkup to answer on his requests. It was very clear for us. This initial photo protocol in our office. As you see, he has some direct restoration in the anterior region, and he has, you will see later on, obviously some tooth wear. In anamnestic data, this tooth wear was produced by mechanical reason and the chemical reason, and the third reason why he has this tooth wear, why he wanted to have a better smile. His hygiene wasn't so good in the past, like maybe is now. So when we speak about minimal invasive approach, there was dilemma how to approach small dilemma how to approach this patient. He's if 28 for me is still very young, but if we remove these all composite fillings, if we remember that he was asking for us for a long period of time, he doesn't want to do nothing on his teeth instead of removing calculus and oral hygiene 2 times a year. So for a long-term period, I choose indirect restoration. In this case, there was implementation for all types of preparation, for all types of which fixed prosthodontics are giving to us. I was decided in posterior region to do zircon crowns, high translucent zircon crowns, and anterior region where it's possible to make veneers when I have enough enamel, and where it's not possible to do is my choice was to do the crowns. In this case, there was no such a big, we didn't increase in vertical dimension, because we increased maybe a little bit, but he didn't have any problems with in vertical dimension, I had enough space to increase his smile by not increasing vertical dimension. So this is the walk-up. This is very important phase for, I think, for every practitioner, because it gives us, we use it for three purposes. I use it for make provisionals because I need it to, when I start the preparation and I send patient home, I need at the end to do some provisionals. The most important thing is for walk-up is we can produce a mock-up so patient can see our choice of the shape of his tooth. And for example, it's very important when you are increasing the length of the tooth. And after, according to next phase is a mock-up. Mock-up is for me at the beginning of the therapy the most important phase, because you can, after mock-up, you can have a feedback from the patient. Yes, doctor, that's it. That's how I want to look, and you are very happy as he is. Or you can receive the information as a feedback. I don't like this. Can you change this? And everything is not the problem because we didn't start therapy yet. Sometimes it's hard for patient to understand that the color of the provisional of this material is the same. The translucency of the of this plastic material is not like the ceramics, but I think still it's much more understandable for the patients than the DSD. Why I always do the mock-up? Because this is the three-dimensional, and patient can, very often before I start, I put the mock-up in the patient mouth and I say, let's see each other in the 2-3 days. And it's a very good influence if he's very satisfied for his family, or for his friends where he's living. And if he's in some dilemma, why is it good, how his dental team had plans for his smile. And after 2-3 days, he is coming back to our office and he says, yes, we can start. So I think it's a very, very good. If you send him on the cell phone pictures of his DSD smile, it will be maybe good on the pictures, but if you finish your therapy, then it could be some problem with, I didn't imagine it will look like that. I thought when you showed me pictures, so to avoid these problems, I think it's necessary to do the both approach, but for the mock-up is for me is very important. This is the preparations which are, as I said before, many types of preparation, because our basic approach, as I mentioned on the slide when I speak about modern dentistry, is minimally invasive. It's very hard when you have this such a case like this to be minimally invasive, because in the end you have to prepare for the most of the teeth for the full crown. But what's important for this situation is I hope you remember the initial photos. You will see it later on. There were many old direct restorations which were not, for me, good polished. After that, we need to replace them. This is for, if you choose this kind of therapy, this is very, how to say, reversible, because after, I think, 5, 6, 7 years, we will do the same procedure again. His demands and my approach is usually indirect. When there is a situation, do indirect, and you see how clear preparations, how clear abutments are now. If you, for example, see upper jaw, the tooth number 2-1, there is a small fragment which you need to replace with the composite. But when I do there was the part where all the direct restoration was there. I have a good cements, and I don't fill this with the composites. I align on the cement, and the cement will fill this kind of cavity. As you see the lower jaw, there was many, when I prepare for the crown, I mostly, my type of preparation is with small chamfer, but sometimes when we have a much destroyed, where the teeth are destroyed very much, this is maybe something combination between shoulder and chamfer preparation, especially in the posterior region. When I'm doing veneers, I most of the time doing butt joint preparation, especially when I want to increase the length of the tooth. For example, if I want to change the color, sometimes the window preparation, it will be enough because you don't have to increase the length of the tooth. But you know what's the biggest problem in the bonding is the margin. If you are you're aware of one margin, which is on on the junction between soft tissue and border of the preparation. And if you do the window, you have then two margins, because you have to be aware in the future that the margin on the incisal and on the cervical part won't get it will remain the same for on the day when we put the veneer and on the day when it won't change the color. We hope so. You are much sure if you do the butt joint, or if you do if your margin will be on the palatal, or if you're speaking about upper jaw, or the lingual side if you speak in the lower jaw. When you speak about type of the preparation, I think the most important rule when you are preparing the tooth is it has to be morphology driven. You have to respect where is the enamel, where is the dentin, and as much as possible to have enamel, and this is I think this is the most important way we are speaking about the most important rule when we speak about preparations. Now you see the scan of the upper jaw, so this is also a good checkup for every practitioner, how your preparation looks. To be honest, they're always looking much more uglier on the scans than on the photos. I forgot to say that is one basic rule by the preparation. It's very important when you finish the preparation to use a red burr or a yellow burr for the finish, because it will make a smoother surface, and which is not so important by the surface, how important in the margin. When you're using microscopes, or when you're using, I saw one good webinar a few days ago by Dr. Kunkela. He was speaking only about margin, and he had some microscopic views. I think was I don't know how many magnification it was. It was not dental microscope. It was professional microscope, and I was very surprised when I think that I'm good repolish the surface of the chamfer, and how it looks when you use red burr, or when you don't use, when you finish with the green, or let's say black. So this, in trying to be a minimal invasive, we had by these patients about 28 units, I think. And for example, tooth number 16, it was inlay, because I didn't want to prepare the whole surface of the tooth, because it was unnecessary. It was a molar region, and I tried to avoid, because of the young adult patient, my approach is to be mostly minimal invasive. If you see further on the tooth 14, it's a very strange, unbuttoned, it's very strange look. You know, the surface, oral surface, it was almost untouchable in my preparation, because this is his mechanical tooth wear on puncture on this point. I didn't use any burr on this surface of this tooth. So this is I'm mentioning because this is what I mean when I said it has to be morphology driven. We can just stick to just stick to this idea, and we will think about this and preserve much tooth as possible. You see the teeth in the lower jaw, the teeth 4.3, 4.4, and 4.5. There are some veneers. It's very hard to say it's veneer. It's some combination with onlay and veneer. But as I mentioned today a few times, it is unnecessary to prepare the tooth from the oral surface because I don't need it. I don't need it because the teeth is looking very, he is very healthy from this oral side, and I didn't, according to the modern dentistry, with the good ceramic materials and cements, it's very unnecessary to prepare the whole tooth. Why I choose to do crowns in the anterior on the incisors and canines this one canine I did the veneer. Why I choose to do crowns? Because they were these natural tooths, because they were so small, and I will be no one from us want to have complaints in the future or have broken veneers or something. And I decided that I will be much successful, much more comfortable by choosing this to do the crown instead of the veneers in the lower incisors. So this is the final work, all 28 units. This product can be provided in two ways. Of course, it's all done, both ways are digital, but there are different approach when you are doing when you're choosing the lithium silicate ceramics to do. This is the Celtra Duo from Dentsply Sirona, and this is on molar region. There is high translucency zircon also from Dentsply. What is important by this work can be done digitally on two ways. One way is, you know, that every block, every type of ceramic today can be milled, and I mean zircon and lithium disilicate and aluminum, so they all can be milled. And this kind of case can be do it normally if after you send the scan and to your dental technician. He is taking a ceramic block and he milled this unit, and after that he staining and glazing in this. This is not only structure in the anterior, and this staining and glazing will be done individually by the technician. Other way is how it can be produced. There is a wax disc, and this case is done on this way. Our dental technician, they chose they use after they receive the scan, they do the whole design and they milled the wax. This is the wax disc, like a PMA disc. It looks like the same, almost the same. And when they get the unit from the wax, they pressed, and it was normally analog way of pressed ceramic how is produced. So I think it's a very good outcome. Which way they will do, I leave to my dental technician. For me, it's the same, but for me, only which is important for me, it has a long term, and it's a period my patient will using this, and that it looks really nice when we cement it. So the hardest way for me, as I mentioned before, is, and I would like to, if it's possible in the future, only to do the preparations and to do the planning, and some, if I will have some other colleagues who only want to do the bonding part, the cementation part, that would be much happy, because you can produce the perfect work. Your dental technician can produce the perfect veneers, perfect crowns, and now you, when you cement it, everything can goes wrong because this is the most sensitive part of the, I think, every therapy. What is it? What is today when you're doing digital? What is easier when you are digitalized? For example, many of us, I'm speaking in my name, I'm few times every second, fourth therapy, I'm start to doing start to cement veneers. And for example, one of the veneers, if it's feldspathic, I break it, or if it's lithium silicate, sometimes it comes in some, you press it and it goes. For example, the light curing is immediately in not perfect position. You have to replace it in digital. When you're doing digital, you can get a new unit in one or in 1.5 hours. So we'll speak about a little bit later. But the procedure by the cementation, we have to prepare the tooth, and we have to prepare our crown or veneer. When you're using the care materials and the cement that I use in this case, there is a same approach for crowns, of course, and veneer. This is all the same ceramic. You first use the hydrofluoric acid, and then after that you use care silane or OptiBond extra. You have to decide, would you to do the total edge technique, or will you do the self edge technique? This case was done by total edge technique. I prefer this technique much more because I'm avoid one step in comparison with the self edge technique. We were using first we put the hydrofluoric phosphoric acid on the tooth for 15 seconds. After that, we gently air dry it, and we put the OptiBond Solo Plus for dentin and enamel for 15 seconds. After 5 seconds of air drying, we're light curing. Our tooth is prepared for receive veneer or crown. In other way, how we can prepare the tooth is a self-edge technique. This is the when we do in the self-edge technique, we use OptiBond extra. It has two components. So you first, of course, dry the tooth, then you put the primer for 20 seconds. After that, you will put the after air dry after a shortly period of earthing for 5 seconds, you will put the adhesive, and after 5 seconds we will light cure it. So we have one step more in compared to the total edge technique. This case was cemented by NX3. This is Nexus 3rd generation. I like this cement because it's very easy to handle with him. I will explain you later more. But what is good for this? There's two ways. There are dual cure and light cure option. When I'm bonding the posterior crowns, I want to be quicker, and especially in the lower jaw, there is always possibility to that some saliva can come, either you put the rubber dam or not, and I want to be very quick, and I'm much more safer with the dual cure way by using dual cure cement. When I'm cementing the veneers, I much more comfortable with light cure cement because I want to be sure that I position my veneer properly, that I put away all resins which I don't need. So it's easier for me to always to do the veneers with the only with the light cure. What is good with this is this cement has also usually they're all in 5 colors. They're clear, white, yellow, bleach, and white opaque. it is a very good aesthetic outcome. It is of course amine free. The adhesion is also very good because I didn't have problems with losing any veneers. It can be lost, of course, by many factors. One of the is for sure is the choice of the cement, and it's more what is more, I think, much most important for the every practitioner by handling with all materials, all cements. It's very easy handle. It's very easy to remove the extra resins, and it is compatible with all bonding with all bonding systems. This is the shortly workflow how we done it. So on the first page you see the trying paste, then you see the abutment which is prepared, which start to be prepared with the acid, with the phosphoric acid. Then we use the OptoBond Plus, and after that we prepare, we put the cement and the crown. As you see, I didn't use the rubber dam in this case. Mostly, to be honest, this is how I work. For this, I need 2 days, or at least I need about 4 hours for every job. If you consider that usually I do it on 2 ways. I cement one job. It depends of the patient. He need to be peaceful. He need to be very he shouldn't be tensed. So answering on the phone or something, I need a much more. I need a lot of time to cement such a case of 28 units, and I wanted to say that it was done in 1 day, but he came in the morning, and he came after he was in our office for 3.5, 4 hours, and he left home and he went in the afternoon. This is the best way if he can appear 2 times a day, because I'm sure that he won't break it during the lunch or something, because occlusion is not safe because he doesn't have all units in his mouth. And I want to mention the rubber dam. I don't have such skills to put rubber dam on 28 units. So when I have a smaller number of units, of course, especially in the lower jaw, we try to use it. But can you imagine this case? You put the clamps and you need to cement 28 units, and the clamp and because of the clamp, the tooth start one unit or 2 units start to bleeding. It's very hard to stop the bleeding when you have 28 units instead when you have 3 or 4. So I try to how I'm doing this. I try to do jaw by jaw, or for example, anterior region, upper and lower, and after that he comes another way, and then I do posterior in the one jaw and posterior another jaw. Sometimes I do it on 3 times, but usually try to do it on the 2 times, 2 visits. When you speak about cement in the posterior region, there is also a very good cement which I could use in this case, but in this particular case I use all Nexus 3rd generation. This is for me the maybe very good product, very good cement. It's Nexus Universal. What is so good by him? You have only four steps. It means 2 steps on the abutment and 2 steps on the crown. So when you put it has as you see the color indicator, and when the pink color is disappearing, you are ready to remove the resin cement, and the process is finished. So this is the final outcome. This is how our patient appeared when next day when we we are finished our bonding. So in this case, when I spoke about digital tools and digital dentistry, what this makes you quicker? It makes you quicker much more that this is all done by without putting the cords. It's also not easy to put in a 14, 15 by Joe cords, and then after that they put impression material, take impression, and you see on the, I don't know, 14 or 13 units are good impressed, and the one unit you had problem with the course or some saliva or blood came and you have you don't have a sharp margin, and it's now of course problem for dental technician. When you do the scan, it's perfect to avoid such a kind of problems, because there is no you immediately see is everything is clear, and your technician immediately receive it, and you save a lot of time. And of course, for the patient is, I think, is much more comfortable to have to be scanned or analogically have a tray in his mouth. What I mostly, when we speak about this product, what I like is to when I would like to recommend the patient don't lose the character which you of the tooth which you had. It's easiest to achieve the white, to have a bleach, because or to have the tooth in one line. This is the easiest for every technician, and the easiest, of course, for our when we do preparation. As you saw, this canine in the lower left canine, number 33, he was very out of the line, and when I do the plan when I had discussion with the patient, I said, don't lose your character. No, when someone sees you after when you appear, I don't know, with friends, with family, after with a new smile, they will see that it's something new. But when you appear, when the people who are not seeing you every day, they have to check what's if we do the bleach, if you do the universal teeth without the character, they will take a look at you, and they will say, oh, you have a new teeth. But what the people have to say when they see you, for example, someone who didn't see you for a long period of the time, when they look at you, are you shaved a beard, are you have a new haircut, they have to notice that something is new happening with your smile, but not punctually to say, when the people not punctually the new teeth. That's what I want when I have a patient who won't try to listen to us. For example, what I spoke about before, you see punctually on this photo. As you see, we couldn't our dental technician, they can produce the same incisors, the same line, the same length, the same line and everything. But I wanted to not to do the same, because you know that the gingival line is not the same. If you want to do the same thing, then the same level of the tooth, the same shape of the tooth, then we have to do in this particular patient in the lower jaw, we have to do the gingivectomy for reshape the soft tissue. So I'm very happy with this outcome, and so the patient, in this case, we broke as you see on this photo, we broke the crown 1/7. So this is then we cemented after. 1/6, as you see, is an inlay. The color is not the same, but the buccal surface of this molar was untouchable. It was a little bit yellow, but he agreed it's not important for him to prepare the whole teeth. So I think I decided without asking him, but I will never prepare the whole crown for such a case. So I think the very good outcome was this. It was very hard cementation for this patient, because he has so much saliva, and when he was speaking, he was very healthy, very young, and we had the problems for secure the area without saliva and to be dry. And this is the upper jaw. I think the margins are very good. Don't forget that this is done full digitally, and it is done. There was no cords putting in the gingiva sulcus, only scan and final produce. As you see, when I spoke about in this situation before and after, on the left side you see incisor, the character of the incisors is the same. So you see on the before tooth number 4.4, we produced here 4.3, 4.4, and 4.5 veneers. I just use the burr or to show the margin to my technician, to my scanner, and I didn't prepare on the vestibular occlusal part of the tooth. I didn't prepare anything. And this is, you see the lower incisors, the 2.2, the 4.2, how small it is. I was much more secure with the crown than veneer in this case. And as we compare it with before and after, I think it's a very, very good outcome and very, very nice, nice appearance with his new smile. So this is how he looked before and how he looked after. I think it's a very good result. I like this ceramic. It is very quick, can be done, and I would like to say hello to my technicians, Ante and Darko. I hope they are listening now, and we have very good this collaboration with using digital tools, and we have a very good result. At the end, I would like to say that every part, every case is very individual, and there is no there is no formula how you can approach to generally to every patient. When you see the patient, when he appeared, when he come to your office, you at that time you have to you can't choose type of preparation, you can't choose the type of ceramic which you use. You need to make a good treatment plan, and then you can start to do the good therapy with a good outcome in the end. Generally, it is easier when you use the digital tools in your daily work. You will get quicker. You will save your time. As you remember, maybe 25 minutes ago I mentioned no one takes care about our time. It's not how we can measure our time. What's the price of our day in the office? We only charge our tooth, only charge work of our dental labs. But if you want to have a quality of your life, you have to take about time, how you spend your time during your daily work. I hope I had your attention. It is very strange experience for me, but it's for the first time that I'm speaking, as I said, without audience. So I didn't need someone take a cell phone to have a photo of some of my slides, or you don't see the audience. Are you boring or you are interesting? I generally hope you like this webinar, you like this presentation. I would recommend you to, there on daily basis, the webinars from KaVo Care, very, very interesting webinars. And I can announce you for 27th of April and 4 p.m. there will be another webinar which I will be presenting. I will speak about microdentistry. I will speak about using microscopy in prosthodontics, and I will show one nice case I'll mention a few cases, but I will show you, like today, very nice case which was done by using of optical devices. Generally, I use microscope and loops, but I will speak about using microscope in dentistry. So there is a very nice sentence before the end of our colleague Stanley from Portugal, which he said that patient-driven scientific approach and minimal invasive treatment powered by awesome digital technology and new material is the new norm. So this sentence, I like this sentence because it's his sentence, but I'm pretty sorry that I didn't write it before him, because this is how I treat the whole situation and how I doing my dentistry today. I hope in this period of staying at home without the dentistry, you still, all of you have the same passion with dentistry, and I hope very soon we will get back in our dental offices and start to produce new smiles and doing great job in our office. So thank you for your attention. Now I will stay here for the questions, and I hope it was very interesting experience for you, and stay tuned to the KaVo Care webinars, and see you on 27th of April at 4 p.m. on the same platform. Thank you.
Kindly unshare your screen so you will see all the questions or comments.
Yeah, okay.
Which one technique for cementation you recommended, total edge or self edge?
Which technique for cementation you are? The colleague is hearing me now, okay?
Yeah.
Yeah, okay. I recommend, I use mostly total edge because I avoid unnecessary step for using primer and adhesive. So generally, I prefer total edge technique because I'm quicker. That's the reason. When we in my office, when we do the cementation, there are 4 of us who are doing the cementation, 3 or 4, because I'm the putting. I have my assistant who is preparing the units, and I have another assistant who giving me adhesive, giving me phosphoric acid and so stuff. So because I'm so, sometimes I'm it's so sensitive work, and it's very necessary to have a good assistance and to avoid unnecessary steps during the procedure. I hope I answered on this question. Is there more question? So that's all, huh?
Yes, there were no questions in the beginning.
Okay. Okay. So if someone wants to ask something later, you just can send me on Facebook or something, so I can answer, of course, further. Okay.
Okay, it looks like there are no more questions. So, Pavle, thanks a lot for this webinar. I'm really impressed about the knowledge you presented and the presentation clinical case. Thanks also to all the attendees. I wish you a nice weekend, and let's stay in touch for the next webinars. Thanks a lot.
Okay, bye. Bye to all. Disconnect.